Bronchodilators. What are they? How do they help people breathe? And do they have side effects? Join us and our patient Josh through the video to get answers.
Bronchodilators are used for conditions which cause narrowing or inflammation of the airways, or bronchoconstriction. Bronchoconstriction is primarily caused by two chronic respiratory conditions, asthma and chronic obstructive pulmonary disease, or COPD. Environmental triggers and/or long-term exposure to toxins can cause a multitude of structural and physiological changes, one of which is bronchoconstriction. Continue watching to see how these affect lung physiology. As we can see, each lung comprises a bronchus branching into bronchioles to the alveoli. These structures consist of smooth muscle and are lined by mucus to allow for effective breathing, also called ventilation. In a healthy lung, air passes through the bronchi into the alveoli, and oxygen diffuses into and carbon dioxide out of the bloodstream. This process, known as gas exchange, requires adequate ventilation, which in asthma or COPD is compromised. The exaggerated immune response in asthma causes bronchoconstriction, requiring the use of a bronchodilator. This interferes with parasympathetic control of the airway smooth muscle, causing bronchoconstriction, tissue inflammation, and excess mucus production, affecting lung physiology. The parasympathetic nervous system controls the smooth muscle in lungs through releasing its chief neurotransmitter for communication between the nervous system and the muscle, acetylcholine. Acetylcholine binds to muscarinic receptors M2 and M3. Muscarinic receptors control smooth muscle tone, mucus secretion, blood vessel dilation, and inflammation. The binding of acetylcholine to M3 receptors in smooth muscle of airways promotes muscle contraction, reducing the space for air to move through. In normal lung physiology, M2 promotes bronchodilation by limiting acetylcholine release. In asthma, M2 receptors are dysfunctional, resulting in airway hyperresponsiveness to allergenic triggers. These include stimuli such as pollen, dust, cold air, and exercise. Bronchodilators have mechanisms to reverse this construction. Continue watching to find out. COPD is characterized by irreversible damage to airways caused by toxins such as cigarette smoke. The damage caused by these toxins is irreversible. While bronchodilators can help manage the symptoms, they cannot reverse the damage. COPD is divided into emphysema and bronchitis. Emphysema occurs when alveoli are damaged, reducing their elasticity or ability to expel air. This causes air to be trapped in the lung, termed hyperinflation, preventing adequate airflow. Bronchitis is characterized by narrowing of airways, which can be caused by excessive mucus production and airway thickening. Bronchodilators are fundamental in the management of COPD. They act to dilate the airways, increasing airflow and decreasing the hyperinflation caused by COPD.
There are three major classes of bronchodilators: beta-2 agonists, anticholinergics, and xanthians. This video focuses on the class of beta-2 agonists and the medication salbutamol. However, a brief overview of anticholinergics and xanthians will be provided.
When you think of asthma medications, you probably think of a Ventolin inhaler. Ventolin, or salbutamol, is one of the most common treatments given for asthma management. Salbutamol, a type of bronchodilator, is a short-term beta-2 agonist. Salbutamol is classed as an agonist as it interacts with G-protein-coupled receptors to initiate the physiological response of bronchodilation, further preventing bronchoconstriction for up to 4 hours. It is most commonly administered via a small, handheld inhaler, but can occasionally be administered as a tablet, syrup, intravenously, or through a nebulizer. However, the most effective means of administering this medication is via inhalation, as it directly targets the affected tissue and does not go into systemic circulation, reducing possible side effects.
Beta-2 agonists are stimulatory to muscle, mimicking the action of hormone catecholamines adrenaline and noradrenaline. They work by forcing the airway muscles to dilate during bronchoconstriction. Importantly, beta-2 agonists only treat the acute symptoms of asthma and occasionally COPD, but not the underlying pathology. To explain how beta-2 agonists work, we will see how salbutamol helps Josh during an asthma attack. To combat the bronchoconstriction associated with an asthma attack, Josh uses a salbutamol inhaler. To maximize its effectiveness, Josh may use a spacer. He exhales completely, then when he inhales, he presses the button on top of his inhaler, ejecting the medicine and inhaling it into his lungs.
Lining the muscles in the airways are receptors called beta-adrenogenic receptors, which are coupled to stimulatory G proteins in the smooth muscle cells. When Josh inhales, the salbutamol binds to the G protein-coupled receptors in the bronchioles, causing a conformational change in the receptor, activating enzyme adenylyl cyclase. This causes a cascade of reactions. Activation of adenylyl cyclase increases intracellular concentrations of cyclic adenosine monophosphate, or CAMP, which lowers intracellular calcium levels. This activates protein kinase A. Protein kinase A phosphorylates and inactivates the myosin light chain kinase and activates myosin light chain phosphatase, causing the smooth muscles lining the airways to relax, allowing for dilation of airways and increasing airflow.
Bronchodilators can give rise to a multitude of adverse side effects due to activation of the sympathetic nervous system. The common side effects of beta-2 agonists such as salbutamol can include insomnia or habitual sleeplessness, trembling, particularly in the hands, headaches, palpitations or sensations of a pounding heart, muscle cramps, and nervousness.
Anticholinergics are a group of drugs commonly used to treat COPD. They work by inhibiting acetylcholine activity at nerve synapses. Acetylcholine usually has parasympathetic activity. It decreases heart rate, dilates blood vessels, and causes bronchoconstriction. Acetylcholine is released as a neurotransmitter from cholinergic nerves supplied by the vagus nerve. Anticholinergics work to counteract parasympathetic activity by inhibiting the effects of acetylcholine. They are antagonists of the acetylcholine receptor and thereby prevent mucus secretion and bronchoconstriction from occurring. To find the mechanism of anticholinergics, let's look at what acetylcholine usually does at the cell membrane. Vagal stimulation causes acetylcholine to flow through and bind to the M3 muscarinic receptor. This causes a reaction cascade to occur within the cell. A G protein is released, and this activates an enzyme called phospholipase C. This converts PIP2 to IP3 and DAG and causes a calcium flux within the cell. This governs bronchoconstriction and mucus production from the submucosal glands. Anticholinergics can be used therapeutically as they inhibit this pathway from occurring and therefore prevent bronchoconstriction and excessive mucus production.
The common side effects of anticholinergics such as ipotropium include constipation or irregular and difficult bowel movements, dry mouth, coughing, and headaches.
Xanthian derivative theophylline is usually considered the third-line treatment for asthma and COPD as it performs the same effect as beta-2 agonists but requires a high dosage, which is associated with severe side effects. Unlike anticholinergics and beta-2 agonists, Josh would take theophylline orally through a tablet or intravenously in its salt form aminophylline. There have been many theorized mechanisms for how theophylline causes bronchodilation, but none have been proven. Theophylline may be administered as an additional bronchodilator if asthma or COPD are not controlled on other medications.
Theophylline are extremely toxic at high levels. Some common side effects include diarrhea or watery stools, arrhythmia or irregular heartbeat, insomnia or habitual sleeplessness, nausea and vomiting, and headaches.
Due to side effects associated with bronchodilators, certain health conditions may be directed to avoid these medications due to risk of complications. Others may still be able to take bronchodilators due to the benefits outweighing the risks, but should remain closely monitored. Due to concerns of congenital malformations in newborns, pregnant women should avoid the use of beta-2 agonists unless necessary. Patients with a history of heart failure should only take beta-2 agonists if directed by a doctor, as some studies have suggested they may increase the risk of heart failure. Patients experiencing hypothyroidism should consult doctors on suitability to take bronchodilators, as onset of asthma may be associated with hypothyroidism and should thus be treated for thyrotoxicosis to reduce these asthma symptoms. Due to risk of increased blood pressure and blood glucose levels, patients who experience high blood pressure or have diabetes should avoid the use of bronchodilators unless prescribed and monitored by a doctor.